Welcome to today's Explainer, everyone. When we walk into a hospital or a clinic, we are placing an immense, almost unbelievable amount of trust in the hands of medical professionals. We just naturally assume that the systems designed to heal us are, well, foolproof. But behind the scenes, the reality of ensuring patient safety is this highly complex, continuously evolving battle against both human and systemic error. So today, we're going to unpack the unseen realities of hospital safety. We'll look at how medical protocols actually work to protect patients, why they sometimes break down, and what it really takes to build a resilient healthcare system. Okay, let's dive right into this. Here is our roadmap for today. First, we'll look at the reality of medical error. Second, the Swiss cheese model. Third, the deadly documentation trap. Fourth, strategies for safety. And finally, our ethical duty. Part 1. The reality of medical error. Let's look at the true scale of harm. Before we can even begin to fix a problem, we absolutely need to understand the true, startling scale of it. And it's pretty shocking. The World Health Organization reports that 1 in 10 patients experiences a medical error during healthcare. Just think about that for a second. If you have a family of 10 or you're sitting in a room with 10 friends, statistically, one person in that group will be subjected to an error when receiving medical care. Patient safety is essentially defined as the absence of this entirely preventable harm. To put that into perspective, when we break down a sample of nearly 1 million reported incidents, a really crucial reality emerges. The good news is that the vast majority, over 630,000, thankfully result in no harm. Phew, right? But the consequences scale up very severely. Low and moderate harm incidents easily reach into the hundreds of thousands. And tragically, over 3,700 of these errors result in patient death. Systemic failure isn't just an administrative oops. It's literally a matter of life and death. Moving on to Section 2, the Swiss cheese model, or how systems actually fail. To stop these deaths, we have to completely shift our paradigm away from just pointing fingers and blaming individuals. And James Reason's famous Swiss cheese model brilliantly illustrates exactly how we should be thinking about it. Imagine every single safety protocol in a hospital as a slice of Swiss cheese. Each slice is a layer of defense against a hazard. But, just like the cheese, every layer has holes in it, little flaws or gaps. Normally, if a hazard slips through one hole, it's stopped by the solid part of the very next slice. But when we analyze major accidents, we see that disasters happen when the holes in multiple slices align perfectly, allowing that hazard to pass all the way through to the patient. Now, to understand those holes, we divide them up into 2 categories. First up, active failures. These are the immediate triggers, the unsafe acts or errors committed by people right at the sharp end of this system. The doctors, the nurses, the people directly interacting with the patient. We're talking about the wrong medication dosage calculated in a rush or a misdiagnosis made on the spot. But these active failures, they rarely happen in a vacuum. Let's look at how this builds with our second category, latent conditions. These are the holes created by management and system design. They're the sneaky, hidden, systemic flaws. Things like inadequate training protocols, confusing medical device design, or chronic understaffing. They just lie dormant in the system for days, weeks, maybe even years, just waiting for an active failure to trigger a catastrophe. The relationship between these 2 failures is actually perfectly captured by an iceberg metaphor. The active failures, that immediate mistake made by an exhausted clinician, that's just the tip of the iceberg visible above the water. But the massive invisible threat line beneath the surface represents all those latent conditions. If we only ever punish the clinician at the tip of the iceberg, we are doing absolutely nothing to melt the massive systemic dangers lurking down below. All right, part 3, the deadly documentation trap. This is when written records fail us. Let's ground this theory in everyday practice. Because one of the most common places where those Swiss cheese holes align is in patient documentation. Take a listen to this actual incident report. Quote, patient received from intensive care the evening before. Patient on oxygen via nasal cannula. Patient's oxygen saturation levels not monitored throughout the day. Unquote. I mean, that is genuinely terrifying. A highly vulnerable patient transitioned out of intensive care, and a gap in communication and monitoring left them completely unobserved. This right here is exactly how a lack of thorough documentation creates an immediate, severe threat to patient safety. The trap doctors fall into is usually caught between 2 extremes. On one side, you have the immense dangers of cutting corners, doing incomplete evaluations, and doctors simply free-typing notes without structure, just assuming the information is correct.
On the other side, the much safer side, you have full, conscientious documentation and the use of pro formas. Those are structured forms that act as a strict aid memoir, quite literally forcing clinicians to check every single critical box. Documentation failures often stem from what are known as the deadly 10 errors. Now, while things like system errors and lack of skill are totally expected, notice the surprisingly human flaws in this mix. Bravado, playing the odds, fixation on a single diagnosis, and even sloth, literally just being too lazy to follow through on the required checks. These deeply human elements are exactly why we need rigid, supportive systems in place. Section 4, Strategies for Safety. Let's talk about building true resilience. So, how do we actually build those resilient systems? Well, optimizing patient safety is a two-way street. It requires a dual approach. Individually, doctors must cultivate humility. They need to be incredibly conscientious, pay meticulous attention to detail, accurately evaluate their own weaknesses, and crucially, be open about their mistakes. But they can't do it alone. Organizationally, the hospitals themselves must provide robust senior support, proper training, structural tools like those pro formas we talked about, and automated alerts for things like abnormal lab results. The system has to support the individual. And here is a super fascinating addition to those strategies. Investing in reducing patient harm isn't just morally right. It actually leads to significant financial savings and much better outcomes. For example, a surprisingly simple but highly effective tactic is patient engagement. Simply engaging the patient in their own care, making them an active participant who actually understands their treatments, can reduce the burden of harm by up to 15%. That is a huge impact from a simple conversation. Which leads us to our final section, Part 5, our ethical duty, the ultimate safety net. At the end of the day, systems and proformas are incredibly vital, but the ultimate safety net is the moral compass of the medical professionals themselves. Personal involvement in safety covers a whole spectrum. On the proactive side, it's about everyday habits, maintaining sharp self-awareness, effective team leading, teaching, and rigorous training. But there is also a very heavy reactive responsibility. When things go wrong or when a colleague poses a real threat, professionals are bound by the duty of candor. That's the absolute obligation to be open and honest with patients when things fail, along with the incredibly difficult but necessary act of whistleblowing. It all goes back to the absolute foundational ethos of medicine. Do no harm. And this isn't just a suggestion, it's a rock-solid ethical imperative. Organizations like the General Medical Council, the GMC, impose a very strict duty on doctors regarding their colleagues. Listen, if a colleague represents a threat to their patients, whether that's due to a lack of skill, impairment, or negligence, there is an absolute ethical mandate to step in and protect those patients. Loyalty to patient safety absolutely must always supersede loyalty to a colleague. To tie everything we've learned today together, let's walk through the ultimate takeaway. It's brilliantly summarized by the SAFTY acronym. S, sense the error. A, act to prevent it. F, follow safety guidelines. E, inquire into accidents and deaths to find those hidden latent conditions. T, take appropriate remedial measures. And Y, your responsibility. Because at the end of the day, safety is everyone's job. We've seen today that medical errors aren't just one thing. They are this incredibly complex web of system flaws and human fallibility. Our defenses, the Swiss cheese model, rigorous documentation, there are shields, but ultimately the entire system relies on the humans working within it. So I want to leave you with this provocative thought regarding that duty of candor. If you were in that high-stakes environment and you saw the layers of defense actively failing, would you have the moral courage to blow the whistle and protect the patient? It is a heavy, heavy burden, but it is the very heart of patient safety. Thank you so much for joining me on this explainer, and keep asking the tough questions.